All right, good morning, everybody. It's nice to see people in person and welcome to everybody online. I hope I understand the cellular service isn't perfect for everybody across the country right now, so hopefully people can still call in. It is my absolute pleasure to introduce Dr. Sharon Castellino as the presenter for today's Department of Pediatrics Grand Rounds. Dr. Castellino is Professor of Pediatrics at Emory University, the Mark R. Hodgins Chair for Clinical Research, and Director of the Leukemia Lymphoma Program at the Aflac Center and Blood Disorder Center in Children's Healthcare of Atlanta, which is one of the largest leukemia lymphoma programs in the country. Dr. Castellino earned her medical degree from Duke University School of Medicine, moving on to complete both pediatric residency and pediatric hem-onc fellowship at Duke. She completed her postdoctoral training with a fellowship in cancer survivorship at Wake Forest University. Dr. Castellino's career focuses on Hodgkin's lymphoma and the study of outcomes in survivors of hematologic malignancy. On a national and international level, she has led 2 large-scale randomized controlled clinical trials for pediatric and adolescent patients with Hodgkin's lymphoma. She recently published the results of one of these pivotal trials in her first author manuscript in the New England Journal of Medicine. In her role as chair of the Hodgkin's Lymphoma Committee at the Children's Oncology Group, she sets and leads the scientific priorities for the development of future clinical trials to continue to advance the treatment of Hodgkin's lymphoma in children, adolescents, and young adults. The impact of her work is broad, as she is active in initiatives supporting the development of care for adolescents and young adult patients. She's developed national guidelines for survivorship care as part of a COG task force. And her investigator-initiator research has a health equity lens, using retrospective data analysis to focus on examining disparities in outcomes for our most vulnerable patients. Importantly, Dr. Castellino is a skilled, generous mentor to students, trainees, and faculty. She has received numerous mentoring awards that speak to her talents in this domain. Dr. Castellino truly is a luminary in our field. We are so grateful to have her here today. Please join me in welcoming her.
Good morning, everybody, and thanks, Erica, for that generous introduction. It's great to be here. Thank you for inviting me, and nice to see faces who I've known for probably almost 3 decades now, and other new contacts in the room. So I'm going to talk to you today about a disease that I have learned and continue to learn about every day. And for those of you who are not oncologists, Hodgkin lymphoma has really set the stage for the discussions around survivorship and refining our treatment beyond the point of just disease-free survival. These are my disclosures. So today I'll try to characterize for you the late effects associated with the premature mortality and therefore creating a survivorship gap based on historic curative therapies for pediatric Hodgkin lymphoma, and then go to describing what I think are the approaches which I divide into primary and secondary mitigation needed to bridge this survivorship gap. I will also review then for you some contemporary trials and therapeutic directions in North America for pediatric Hodgkin lymphoma, largely focusing on classic Hodgkin lymphoma, and talking both about frontline regimens with targeted agents and novel endpoints that I think are important in terms of a disease where we can give patients choices. So the epidemiology of Hodgkin lymphoma is that it has a bimodal distribution with the first age peak around 20 to 30 years of age. and then another smaller peak in the 50s. The annual incidence of this disease is about 8,000 to 10,000 cases a year in the US, based on the SEER data, and 1,100 of those are in children and adolescents less than 20 years of age. But because the 5-year disease-free survival has already attained over 80% survival in most patients, the prevalence of survivors living in the US is rising. So a basic summary here that is less than all conclusive, but I wanted to highlight because there's nice summary in what has recently developed as pediatric specific Hodgkin lymphoma guidelines in the NCCN, the National Cancer Guidelines for trials and workup of patients, is that a history in physical will often reveal an indolent course of lymph node development that may or may not have received antibiotics. Patients may have some splenomegaly. And then it's important to the staging and the characterization of risk, treatment risk for this disease, to evaluate for B symptoms, which can be vague in terms of fever, drenching sweats, used to say night sweats, and weight loss of maybe 10% or greater of body weight. There's some basic lab work that can be informative, and with time, we're also learning that having things including an albumin may be a marker of severity of disease in addition to B symptoms. The diagnosis is best addressed with an excisional node biopsy, or if incisional biopsies are done, they really need to be several passes because some of the morphology of the tissue is needed to make the characteristic diagnoses. The classic Hodgkin lymphoma has expression of a CD30 positivity throughout. In contrast to nodular lymphocyte predominant Hodgkin, which is really changing in its characterization as potentially crossing into a non-Hodgkin type lymphoma, and that is CD20 positive, and therefore merits a different treatment approach and has a different natural history. So we won't discuss that as much today. Immunodeficiency workup needs to be considered, especially in younger children, and HIV needs to be considered both in terms of any younger child who has a potential prenatal or perinatal exposure, and in terms of our teenage patients who may have behaviors that put them at risk for HIV development. The chest X-ray is always a good place to start in the ER with a patient who may have an enlarged node, just to make sure you don't have any kind of life-threatening situation in terms of a mediastinal presentation, which can be quite common in children. The role of bone marrow is changing with the advent of PET, which can sometimes also have characteristic changes in the bone marrow, and has really made a dramatic difference in our understanding of how to stage the risk of this disease. And then many times we do baseline tests in terms of echo and pulmonary function tests, anticipating the kind of treatment that will be needed. So Thomas Hodgkin first described this disease in 1832, but struggled academically, and in fact was denied a staff position at the Guy's Hospital in London and resigned. So for those of you who are out there in early careers, just remember that things aren't always as appear at the beginning. And then in 1865, Samuel Wilkes resurrected his work in a manuscript entitled On Some Morbid Appearances of the Absorbent Glands and Spleen, which summarized 7 cases post-mortem in patients ranging 9 to 50 years of age, again showing us that nice bimodal distribution, and then credited the disease name to Hodgkin. The characteristic pathognomonic Reed-Sternberg cell that you see here in the bottom left part of the screen was described in 1898 as a hallmark of the lymphoma. And then it wasn't until the 1900s when therapeutic approaches were initiated, with radiotherapy being the primary use of treatment at the beginning, because this is a very radiosensitive disease. And then the use of additional adjunct therapy with nitrogen mustard combinations in the MOP regimen. And then in the 70s, North America, ABVD became the more prevalent regimen used with the drugs described down there below as consolidation with using to minimize the fields in radiation. And then in the 1990s, in the children's oncology group, etoposide and prednisone were added, the E and the P there, to some of these other characteristic drugs. And again, in terms of diminishing some of the late effect risks that were thought to be associated with the pediatric, the adult type regimens. So I'm going to step back for a minute and show you some data that informed how we have moved forward. The Childhood Cancer Survivor Study may not be familiar to all of you, but has yielded very interesting data for us in many of our diseases, including Hodgkin's. The Childhood Cancer Survivor Study, CCSS, is a multi-institutional retrospective hospital-based cohort study with longitudinal follow-up of survivors of childhood cancer. And the initial cohort was in those diagnosed at 31 institutions in the US and Canada. And at that time, the cohort was those diagnosed between 1970 and 1986. And when I did my thesis project for the T32 cancer survivorship, I was able to access and analyze the data from this cohort specific to Hodgkin lymphoma. And what we saw was in a disease where we knew in the 70s and 80s had about 74 to 80% 5-year survival, that when patients entered the cohort, I'm not seeing my, when patients entered the cohort here, having survived 5 years, we continue to see a drop in their mortality over time. And so compared to the US age-matched population, we realized that the standard mortality ratio in males was 6.3 and in females was 12 over the standard population. And while you see that all-cause mortality here in panel B continue to rise no matter how many years you were from your initial diagnosis, that this was not driven by recurrence or relapse in panel C, but in fact by non-recurrence, non-external causes, which I will now describe. So when we examine the treatment characteristics of this historically treated cohort, we saw a couple of things. That in that era, in a pediatric cohort, chemotherapy alone was only used for 6% of the patients. And in fact, a third of patients at that time received radiation alone for curative intent. And then there was combined modality emerging in the other 62%, and anthracyclines were limited to about 26% of the population. And importantly, in the panel on the right, you see that the radiation fields were what we consider now as extended field radiation, with patients receiving either over 30 gray or right at 30 gray for the majority of patients, to both the infra and supradiaphragmatic areas in the majority of patients. And so the consequence of that over time was a couple of different primary drivers of mortality. The first that we found was the increasing risk of second malignant neoplasm in survivors of Hodgkin lymphoma, with a differential rate in females versus males. And the female was all primarily driven by breast cancer cases in the mediastinum radiation field. And so that approaches 25% of cumulative incidence at 35 years of follow-up in patients who were treated as being younger girls. And the other thing I'd like to point out is that these curves don't start to rise until 15 years, which again points to some of the latency of things we don't know about when we're delivering treatment in cancer. The other driver of morbidity and mortality is that of cardiovascular conditions. And here we see again, those curves start to rise at about 10 years with a cumulative incidence of 8 to 10% in females and males respectively treated in that era of 1970 to 1986. So in conclusion, what we learned from the first examination of this cohort in the CCSS was that therapy-related morbidity and premature mortality continued with aging of the cohort, and that the mortality risks were identified as being that of extended field radiation therapy, RT, in females, and the receipt of anthracycline chemotherapy in males. Importantly, that I'd like you to remember for latter part of this talk is that relapse is a significant independent predictor for mortality because it is a curable disease with additional therapy, but salvage has its cost that comes with it as well. And that second malignant neoplasms confer an independent risk, as do cardiovascular conditions. So we moved from the CCSS era to the 1990s, which gave us improved imaging in terms of CT initially, and that allowed us to abandon what used to be surgical staging with splenectomy in the first era. We started to have new combinations of therapy in pediatrics, and radiation delivery was able to be refined and moving from extended field radiation to what was then termed involved field radiation. And I'll show you some pictures to describe those changes. Then in 2000, we had a new generation of trials in this children's oncology group that moved to a risk-adapted approach, which wasn't the case previously, where patients who had low stage disease and low burden of disease got less intensive treatment, and then those who had higher intermediate or high risk disease got more intensive treatment and differing radiation approaches. In addition, we adopted a response-based approach, given that we had FDG PET emerging as a way to monitor disease burden in the interim part of therapy. And so the early part of that era was then captured in an expansion of the pediatric experience in the childhood cancer survivor study, and in fact showed that already we were starting to see decreases in morbidity in terms of this article that was first authored by Dr. Effinger et al., where we saw a decrease in grade 3 to 5 chronic conditions. The bottom teal line here represents a cohort treated in the 90s in contrast to the cohort in the 70s and the 80s who received the treatment I first showed you on that pie graph. And then this translated to a decrease in 15-year cumulative mortality. And this is the Hodgkin's experience in a cohort of all childhood cancer survivors that was published by Greg Armstrong and his group. But you can see over time that the bottom line, which is sort of a gray-green line here, we were seeing a decrease in the cumulative mortality over time. So reflecting treatment changes and refinement of radiation. And so therefore, the primary mitigation for the gap that I described just now in survivorship is to improve our treatment through clinical trials. So the goals of contemporary trials has been to maintain event-free survival with events described as relapse, death, or second cancers, and to maintain overall survival. That has been done by looking at ways to reduce normal tissue volume exposure to radiation, both by decreasing the rate of use in response-adapted paradigms and to tailoring the dose and the field extent of the radiation. to where possible in lower stage patients to decrease the cumulative alkylating agent and anthracycline doses, which are known to be associated with several different late effects, and to evaluate now novel agents in children and adolescents through collaborative efforts. Importantly, I'll demonstrate that we have also started to incorporate patient-reported outcomes on specific symptoms and on health-related quality of life to understand a range of side effects from fatigue to peripheral neuropathy, which may be more prominent with some of our newer targeted agents. So after many years of successful sort of give everything to the patient treatment, we finally had biology in Hodgkin lymphoma. And I do think some of our progress in biology was actually paralyzed paradoxically by the early success in 5-year event-free survival in this disease. And so here you have the characteristic Reed-Sternberg cell at the center. And what we have now is CD30 targeted drugs in the form of the first generation being brentuximab vedotin, and also drugs that target the PDL pathway, which is overexpressed. PDL1 is overexpressed in Hodgkin lymphoma cells based on a genetic alteration that is seen in these cells, and that has been targeted by checkpoint inhibitors. I'll now describe some of our experience with these new agents. So AHOD 1331 was a children's oncology group trial that was limited to patients with high-risk disease, at that time defined as those with 2B with bulk, so large mediastinal masses are often present that way, stage 3B or stage 4A or 4B. Pediatric age group up to 21 years of age, randomized trial that looked at a standard therapy here on the right of 2 cycles of ABV-EPC, followed by an additional 3 cycles with an interim PET defining a response-adapted involved site radiation approach versus including brentuximab in that backbone and delivering it in a similar way to determine response-adapted radiation at the end. And we learned several interesting things from this trial. Well, first of all, we saw that the event-free survival in the brentuximab group was 92% at 3 years, as opposed to 82% in those who received the standard therapy. And this was all driven at 3 years by relapse-free survival, with the relapse rate being much lower in the brentuximab-containing regimen. And so we had a really nice paradigm here of being able to do a few different things. One is we eliminated bleomycin from the regimen because the brentuximab containing regimen did not contain bleomycin, which is associated with pulmonary toxicity in the long run. We were able to reduce the proportion of patients getting radiation from where in advanced stage disease in pediatrics, over 70% of patients used to get radiation of some form, and we reduced this to 54%, which at that time was the largest reduction of radiation use in an advanced stage cohort, high-risk cohort. And then excitingly, we had an approval of this drug in combination with AVPC for children 2 years and older with high-risk Hodgkin lymphoma. And this was the first pediatric approval for this targeted agent, but really lagged behind our adult colleagues who had had about a 7-year head start on us in incorporating this targeted agent into their regimens. Now, AHOD 1331 still included targeted radiation, but what I want to show you is that not all radiation is alike. And this is a cartoon that was lent to me by my colleague David Hodgson from Canada that sort of describes this in terms of the CCSS generation of extended field RT, which was associated with some of the data that I showed you in the early CCSS experience in 70 to 1986. involved field radiation, which was used still by us in the early 2000 to 2012 era, and to now where we have refinement to involve site radiation. And you can see the normal tissue volume exposure is dramatically reduced. And while we anticipated that reduction, we in fact now have data to demonstrate that in a few ways. First of all, amongst the cohort that I described to you of 600 patients, about 317 patients received protocol-directed radiation. Only 6% of those were for slow responding lesions, SRL. But the majority of the radiation was actually for bulky mediastinal disease, which was a decision that was made to give that all patients with bulky mediastinal disease radiation, regardless of their interim response. And that decision was made based on our prior era of data. The type of radiation delivered has evolved in North America to where about a third of patients received 3D conformal radiation, 45% received intensity modulated radiation, and 26% were able to access proton therapy. And what you can see here in this schema that was given to me by Brad Hoppy is this is the difference in how the field distributes for those three modalities. And we have now in real time from this cohort who was required, one of the requirements was to deliver the radiation plans that were reviewed centrally, is that the mean heart dose and breast dose and thyroid dose is dramatically decreased over the prior CCSS generation of data, but also delivers differently across these three modalities. And so keeping a track of normal tissue volume exposure while we continue to use radiation, which is an important part of Hodgkin lymphoma therapy for certain patients, needs to be monitored. So I wanted to show you a couple of other things in terms of endpoints that were incorporated into this randomized trial. I'm not going to be able to show you data on all of it today, but we looked at validating something called a CHIPS, which is a childhood prognostic score for Hodgkin lymphoma, as one does not exist right now. And we have data emerging on that. We have biology collected and are currently evaluating circulating tumor DNA to develop a radiogenomics model. We have some PK data on a small cohort of the younger children. And then what I'm gonna, I showed you some of the radiation data, and then what I'm gonna focus on for the next few minutes is some of our patient-reported outcome PROS data relating to chemotherapy-induced peripheral neuropathy and health-related quality of life of all patients on the trial. So this experience has actually set the bar for us to start including the patient voice in clinical trials. And while I'm going to focus on the trial that I just presented, 1331, we have also continued this under the leadership of Susan Parsons and others to look at this in a trial that recently closed that included pediatric and adult patients, S1826, and an active trial right now for early stage disease AHOD 2131. And what you can see here is that we've looked at a variety of symptom reports, fatigue, which has been known to be a prevalent continued effect in patients with Hodgkin's, health-related quality of life, and caregiver burden in certain of these cohorts, and healthcare utilization. For all of these so far on therapy, the instrument completion rates are high when it's put in as a obligatory part, an opt-out only part of the protocol. So chemotherapy-induced peripheral neuropathy has been associated with vinca alkaloids and with brentuximab vedotin, which can disrupt the tubular mechanism in cells. The FACT-NTX is an instrument that was developed for and utilized for decades in actually the ovarian cancer population related to cisplatin-based neurotoxicity, but had never been evaluated prospectively in a pediatric cohort. And so with the developer David Sella, we adapted the fact to include the patient voice and the child voice and looked at parent and youth report simultaneously over time during the trial. And so again, we collected items at baseline pre-chemotherapy, after 2 cycles of therapy, and at the start of the 5th cycle of the 5 cycles of therapy, and then thereafter. And what this shows you, with remembering that a maximal optimal score is 16, which indicates no neuropathy, and lower scores indicating more impairment, is that between raters and then over time, the instrument performed as we would expect, where you would expect the peak dose of the brentuximab vedotin and the vincristine to be around cycle 3. And in fact, that is when you see the highest report of impairment with the decreasing score. And you can see that the parent and child rater was remarkably similar in terms of the scoring. In terms of looking at construct validity, we also looked at clinician report here on the bottom, as both for the youth and the parent reporting of CIPN, and saw that there was nice concordance between the clinician grading of grade 2 or higher neuropathy and the patient rating, as you can see these dropping scores, and the parent rating. And so this also demonstrated an ability to use this data as we go forward in understanding the patient experience with neuropathy. We also had an instrument called the CRIS, which looked at longitudinal health-related quality of life as reported by the child or young adolescent. And what we saw over time, interestingly, is that in brentuximab vedotin arm, which I've already showed you, performed better in terms of disease control, that we started to see separation as early as time point 2, and that the percent of patients here who reached a minimally clinically important difference was overall was different between the 2 arms, in that those who were on brentuximab vedotin, there was 35% who never had the minimally clinically important difference, as opposed to 42% in the standard arm. So showing that even before you saw anything in terms of imaging differences, that there's some improvement as reported by the patients. So I've just described for you the pediatric approach in North America, focusing on ABV-EPC. The Europeans use a slightly different approach of chemotherapy, but both pediatric approaches have historically, even in the last 10 years, used chemotherapy and response-adapted radiation. This differs from our adult colleagues who use ABVD in North America and BIACOP. And I don't need you to focus on what exactly all the drugs are in this, but you can see here that there is lack of harmonization in our approaches, where we know that young adults with Hodgkin's likely don't have a different biological disease than they do if they present to the adult or the pediatric side of the oncology fence. So we realized that in order to accelerate novel drugs into our patients, that we needed to have collaborative approaches. The NCTN is the National Clinical Trials Network, and they have had a goal to increase trial participation for rare cancers and cancers in adolescents and young adults, supported by a centralized system, and with the goal of increasing phase 3 trials and trial enrollment. And an early view of this has shown that we are slowly moving the needle, but as you can see, very slowly for adolescents and young adults who oftentimes don't get represented in clinical trials in cancer. Just a reminder here is that as I showed you earlier, that things come to children about 10 years later than they do for adults, and which is another point for which we needed to think about collaborations, both locally and internationally in partnerships. So the S1826 trial is one such NCTN collaboration where pediatric patients aged 12 to 17 were allowed to enroll. Actually, the trial was open for advanced stage Hodgkin, stage 3 and 4 disease to patients over 12 years of age, and took the opportunity to examine nivolumab with the AVD backbone that has historically been used in the adults in the US, and compared to brentuximab with AVD and given over 6 cycles. The primary endpoint was progression-free survival. And because of our prior pediatric studies and wanting to have some ability to look at the role of whether radiation benefited patients or not, as we have historically thought it did in advanced stage disease, end of therapy radiation criteria were defined in a less conservative way than previously for the pediatric cohort. And what we saw in June of 2023 was that at 1 year, the DSMC, the Data Safety and Monitoring Committee, much to everyone's surprise, released this data because there was already a separation of arms in the cohort overall. So this is about 937 patients, both pediatric and adult. And we saw that the nivolumab AVD arm had a 1-year progression-free survival of 94%, as opposed to 86% in the brentuximab arm. When we look specifically at the pediatric cohort of 240 patients aged 12 to 17 in this group, this effect holds up. Now, the study was not powered to be able to show a statistically significant difference between arms, but at 1 year, you can see that the nivolumab arm has 6 events as opposed to the brentuximab arm, which had 12 events. And so data will be forthcoming in the next year, as there was not inappropriate critique of the early release of this data at 1 year. But it really does appear with these novel agents that the curves do flatten out in terms of events after 12 months of follow-up. And so we will have further follow-up to solidify this data, hopefully by the end of the year. But what we learned from this was a few different things. That nivolumab, which is the checkpoint inhibitor, and brentuximab with the AVD backbone, different than the data I showed you earlier from the pediatric standalone trial, were well tolerated in patients 12 years and older. To date, there have been few immune-related adverse events in early follow-up, and I have that data if anyone wants to see it. I just, for the sake of time, I didn't include the details of that. That in pediatrics, there was less discontinuation of BV, and I think we're going to see that that differed from our adults, which probably drove their brentuximab dose curves lower because the neuropathy is less tolerable in the adult patients we've seen. While the anthracycline cumulative dose went to 300 milligrams per meter squared, over 75% of children received dexrazoxane, which is a cardioprotective agent concurrent with the 300 milligrams per meter squared of anthracycline. Again, a difference in utilization of mitigation approaches from our adult colleagues. Most importantly, to date, less than 1% of patients have received consolidative radiation. And so as you can see, that's a dramatic change in practice in terms of reducing the potential reduction of late effects. Follow-up is ongoing to confirm the durability of the progression-free survival, and overall survival will need to continue to be monitored in terms of whether we can keep our late effects down or whether, we will have to think about a new barrel of late effects with the novel agents that need follow-up over time. So this demonstrated a successful collaboration with our adult colleagues to harmonize approaches potentially for adolescents, and to evaluate how patient-reported outcomes will facilitate management of tolerability. And this gray pie chart here shows that the the children's oncology group actually brought about a third of patients to this trial. And so that has further, solidified with our adult colleagues that it's valuable to include the patients in the trial when there's not a biologic difference known. So many options for Hodgkin's, and really forces the issue of understanding better the shared decision-making model for this disease, where side effects are wide-ranging from fertility impairment potentially to all the other things that adolescents can suffer during undergoing a cancer treatment experience. I'm going to move forward just quickly through a couple of things to show that one of the ways that I talk to patients about these shared decision-making is to look at the current data, realizing there are subtleties. The 1331 and S1826 data did not have the same inclusion criteria at the beginning. And so we need to be careful about just extending this new data to patients under 12, to patients with other stages of disease. I can review cumulative doses in terms of their side effect profile with patients. And of course, the fact that radiation dose would have been higher if it were delivered. But in reality, we had less than 2% of patients who have needed radiation with the nivolumab approach. It's also important when talking to adolescents and young adults, especially, but children as well, the total days of IV chemotherapy, which are different between these two regimens, although overall the regimen is in 5 cycles versus 6 cycles. So trade-offs that patients and parents may need to consider. We have another NCTN collaboration going on for early stage disease, this one led by the Children's Oncology Group. Again, not to have you focus on the details of this regimen, but we are bringing both brentuximab and nivolumab up front for early stage disease. And this will be another way for us to harmonize and collaborate with our adult partners. So key advances in Hodgkin lymphoma driven by the Children's Oncology Group: frontline disease, superior event-free survival with novel agents, brentuximab and now nivolumab, safety and feasibility of incorporation of checkpoint inhibitors. Incorporation of patient-reported outcomes is feasible. We've moved from involved field radiation to involved site radiation with incorporation of proton therapy, giving you normal tissue volume reduction. And we are pending data to look at ctDNA and metabolic tumor volume as potential biomarkers of response. In relapse disease, which I have not shown you the data for today, we have continued to look at reduction in myeloablative regimens with the feasibility of transplant-free management in select populations of patients. And this is all covered in our recent blueprint from the Children's Oncology Group. So I'm going to pivot briefly to some real-world data. Although Hodgkin's has great survival overall, we know that not all groups have benefited equally. Population-based and single-center studies had reported inferior outcomes in non-Hispanic Black and Hispanic patients compared to white patients. In an analysis that was led by Justine Khan, we looked at patients who were treated on 3 legacy trials of Hodgkin lymphoma. So these are patients who actually all went on a clinical trial. And while their disease-free survival was comparable by race and ethnicity, what we saw is that post-relapse, that the survival gap differed. And so we are now drilling down on that to understand, is it access, is it disease? The fact that patients, once they relapse in Hodgkin's, oftentimes have evolved into the adult world, and that to date, autologous transplant and sometimes allogeneic transplant is a curative mode for relapsed Hodgkin's, and are all patients not able to access that equally. In the separate SEER Medicaid analysis led by my colleague and mentee, Dr. Zhu Ji, we see that if you look at SEER Medicaid linkage, which looks at enrollment data and insurance continuity in Medicaid, we see a dramatic difference in overall survival amongst patients who have newly gained Medicaid compared to private insurance at diagnosis and those who have continuous Medicaid at diagnosis. So again, a place where we can look beyond just the constructs, social constructs of race and ethnicity, and looked at policies where we may be able to have an impact so that patients are not delayed in their diagnosis because of and in their access to care because of their disruption of their insurance. And this is demonstrated further in this data, in that if you look at advanced stage, either defined as stage 4 or stage 3 and 4 disease, those with newly gained Medicaid had a higher model adjusted percentage of presenting with late stage disease. So this all calls for action beyond the patient level to improve the diversity and inclusion of minority populations in childhood cancer trials, to invest in transition to post-cancer care, and to improve seamless insurance coverage for patients. So going back to the concept of a survivorship gap, I think I have demonstrated that by refining and titrating frontline therapies, we can reduce exposure to certain agents that have been associated with these various organ toxicities, cardiac, pulmonary, second malignancies, endocrine, and now nervous system. That if we refine frontline therapies, you should have less patients who need high cumulative doses and stem cell transplant. But we need to continue to screen and intervene to attenuate the known and now forthcoming potentially unknown risks of late effects with these agents. So secondary prevention includes, in the Children's Oncology Group experience, exposure-based screening guidelines that have been well developed and continue to be expanded, looking at therapeutic agents, their potential late effects, and periodic screening needs to catch these late effects early in the population. Health counseling, both within the oncology realm, but in primary care and long-term follow-up. So in conclusion, the Childhood Cancer Survivor Study informed movement towards reduction of therapy and tailoring of therapy through clinical trials. Real-world cohorts and extant data informed drivers of outcomes beyond therapy alone. And with the introduction of novel therapy, we need models to follow trial participants into long-term survivorship to understand if there will be latent and late risks of these novel immuno-oncologic agents. This should all be part and parcel of a personalized approach, considering the tumor, patient factors, treatment, risk of adverse events, and social considerations that drive the best outcome for a patient. Future directions are many, and I am low on time here, but CD30 and CAR-T and CD30 directed BiTE molecules are under investigation. Assessing trial representativeness is being embedded into some of our trials. We need pharmacogenomics. We're lacking right now to predict toxicities. And we have data commons evolving that will help us to look at a harmonization of data across adult and pediatric groups. We need to continue to evaluate cardioprotective agents, fertility preservation approaches consistently and affordably for all patients upfront, and then develop long-term models, as I indicated, to embed follow-up in clinical trials. So I went through those last few a little quickly, but I'm happy to discuss those with people. These are my acknowledgements and funding. A lot of the Children's Oncology Group successes in Hodgkin lymphoma were led by my predecessor as chair, Dr. Kara Kelly, and Dr. Frank Keller, who has been a senior advisor on Hodgkin's for many decades now. And then the collaboration with the NCTN group, which includes our Canadian Cancer Trials group, has really been a success and sets the bar for us going forward. And always gratitude to patients, families, and caregivers who participate in research. Thank you.